Good afternoon, everybody. We're just going to let everyone get pulled into the webinar and then we'll get started. All right, everyone. Good afternoon. I'm Kelly McDevitt, the president of IBI. I welcome you today to our webinar on the effects of delayed care on the workforce. Today, we have a great presentation on our research project around this very hot topic. And our director of research here at the Integrated Benefits Institute, Candace Nelson, will be joining us and giving the research results to you all. And then we're going to have a little discussion with Matt Ponicall, who is the Senior Director of Global Benefits at Honeywell, to talk about how Honeywell is approaching this challenge. As you all know, obviously, we are coming out of 3 years of the pandemic, and we all have seen the data that came out in mid to late 2020 about the effects of delayed care from the pandemic. Employers at the time were struggling to keep up with all of the things that the pandemic caused from a workplace perspective, with sending people home, closures, infection rates, etc. And so we really didn't start thinking about delayed care's tail end effects until probably well into 2021. And we all knew that people were delaying care, but there wasn't a whole lot during the height of the pandemic that we could do about it. Doctors' offices were closed, weren't seeing patients, we're only seeing the super sick patients, et cetera, and hospitals were overrun. And so we didn't have a good solution for it, but we all in the back of our minds worried about what the tail end effect of this was going to be. And so that's what we're going to talk about today. You're very interested to research really 3 specific buckets around delayed care. We knew that some people were probably very affected by the pandemic itself, and that there may still be a fear out there of either getting or giving COVID for people that are at high risk, et cetera. And then we also knew that the system is not necessarily back to capacity in certain ways. We have shortages, obviously, of certain types of specialties, shortage of nurses. There are some community and local hospitals that have closed. And so getting appointments and having providers available, we knew was out there as one of the particular drivers as well. But the biggest bucket really is not directly related to the pandemic, because it's affected us all for many, many years. And that is the barriers to care bucket. And obviously, the pandemic did nothing but exacerbate that particular problem. So the goal of our research was to figure out what's happening today and why are people still, or if they're not getting delayed care, why? And so we're going to have Dr. Candace Nelson present the research that IBI did first. And then Matt and I are going to have a conversation about how employers can approach this problem, track the outcomes, and then obviously implement solutions that would affect the effects of delayed care. So Candace, I'll turn it over to you.
Great. Thanks, Kelly. So good afternoon, everyone. As Kelly had mentioned, the survey we fielded in January of this year helped us to provide some information about where people were with their medical care, whether or not they were still delaying due to perceptions of COVID, and investigate the possibility that there were heightened concerns about costs that would inadvertently affect some groups more than others. So I'm excited to present our findings to you, and I will get started. So I want to start off by thanking our research committee for their helpful comments, suggestions, and feedback along the way. So here are the research questions for this study. And in addition to the points I just mentioned, we also examined whether those with underlying chronic health conditions, and so with the greatest healthcare needs, were delaying, and whether there were differences in geographic locations, specifically looking at rural areas, which tend to have less access, And then finally, we spoke to employers about the best practices for mitigating the effects of this important problem. And as Kelly mentioned, after I'm done, you'll get to hear more from Kelly and Matt. So I'm going to start very high level. And while I didn't want to get too academic, I find models useful for thinking through research questions. They give you some nice buckets to use for categories. So for those who find models useful, I thought I would quickly present this. So since the 60s, this model, the behavioral model of healthcare services use, has largely guided our thinking about healthcare utilization. And it's gone through many iterations since then, but this is the basics of it. And according to this model, use of healthcare services is primarily determined by predisposing factors, things like age, gender, education, having children in the household, enabling factors, things like income and health insurance. And this has been a big focus of research because of the obvious policy implications. And then finally, need or illness level. So that's it, simple, which is why it's so great. Okay, so in starting this project, I think, thinking about some of the previous research and what has led up to our concerns and reasons behind conducting this study. So I'll go through some of the previous work. So according to CDC report in June of 2020, some groups were delaying more than others. And these groups included, among others, young people, Hispanic adults, people with disabilities, and people with underlying medical conditions. So in addition to the effect on individuals, there were also systemic effects on the healthcare system. So in August of 2020, a survey of primary care practices revealed that they were seeing decreased patient volume. And they reported also, in addition, reduced number of services and decreased or discontinued staff training. Okay, so now we're up to January of 2022. And according to national data, staffing has largely recovered. You can see that in outpatient care, that's the top blue line, while there was a sharp decline at the beginning of the pandemic, reflecting what I just talked about with what primary care practices we're seeing, staffing in outpatient care has largely recovered. Also, so while the number of clinical staff, so people like physicians and nurses either recovered or remained steady since the beginning of the pandemic, the number employed in other healthcare occupations has not necessarily. So from this graph, you can see that the number of staff in occupations that require less education to enter dropped quite a bit at the beginning. That's a 28% drop. And as of January last year, still hadn't fully recovered. So they were down 10% pre-pandemic. And the other occupations suffered less and have fully recovered. So, however, the national data likely obscures the fact that there's regional differences in our healthcare system. So, in fact, hospitals in rural areas tend to be more vulnerable to adverse economic conditions and staffing pressures. So here you can see the frequency of hospital closures in rural areas since 2005. Okay, so now on to our survey. After reviewing all this information, we wanted to find out where we are now with delayed care in the US. So we contracted with a survey research firm to conduct this study. And in addition to collecting some basic demographic information, work-related information, and health information, we asked respondents if they had delayed or avoided medical care and asked them to provide the reasons. And it was a choose-all situation. And the options were cost, fear of getting or spreading COVID, difficulty finding a provider that would accept their insurance, and because an appointment wasn't available when they needed it. And we also asked them about preventive screenings, such as mammograms, annual physicals, etc., and immunizations for themselves and their children if they had them. And then if they weren't up to date, we asked them why not. And our response was a little over 5,000. So here are the demographics of our respondents, and I've compared them to other larger national surveys and the census, and they reflect national demographics for this age range of employed people. A couple things I want to point out, so that'll be important later on. So about half, 49% of the people have kids under 18 in their household, and 12% live in rural areas. Okay, so we asked about where people work, and here's some information about industry as well as their work location. About 57% of people work on site and the rest work remote or hybrid.
And for the audience, I failed to mention, I apologize. If you have questions as we go through the deck, please do use the Q&A box, and then any questions for myself or Matt during our discussion, we will answer those at the end. So go ahead and put them in anytime.
Yep. Let's see. So we asked respondents about their health. So in addition to weight and height to calculate BMI, we asked respondents to choose from a list which conditions they've been diagnosed with. And conditions with the highest prevalence are obesity at 29%, anxiety 27%, and depression at 24%. And we also looked at some common combinations of comorbid conditions on the graph to the right. Most commonly was anxiety and depression at 17%. Okay, so here you can see that delayed or avoided medical care is most frequently due to cost-related barriers, followed by delays or avoidance because there was an appointment available, and then finally due to getting or spreading COVID.
And Candace will get more into this a little bit more in the conversation, but I think this particular slide really shows some results that we were not expecting. And that is that I personally did not expect the fear of getting or giving COVID in 2023 would be nearly as high as 35%.
To be so high.
We realize that part of the population is at high risk, and that maybe older Americans are less apt to travel out to go see the doctor in this day and age with fear of spreading or getting COVID, but we really did not expect it to be this high. And then the other bucket that was surprising to us was the delayed care due to availability. And this really speaks to, I think, the shortages in certain areas, which Candace will get into as well, that people couldn't get appointments or people had to travel too far, et cetera. The biggest bucket, obviously, and the one that I think employers are most concerned about are the barriers to care. And that at 58% was not surprising. But I think that the other two buckets for us, we were a little unexpected, I think, results. We didn't expect those two to be quite as high as they were.
Absolutely. I think especially the COVID fear one, I was expecting that to be much less. Okay, so now I'm going to drill down into each reason for delaying or avoiding care by demographic characteristics. So here we have delayed care due to cost or insurance barriers. And the average was 58%, but some groups delayed more than this average. And these are people with kids under 18 in their house, people who identify as LGBTQ+, and people of ages 25 to 34. Also people with less education delayed more, and people who made less than $50,000 per year delayed more. So not surprising that cost and insurance barriers are related to income and education for sure. So 35% delayed due to fear of getting or spreading COVID, as we just said, but some groups delayed more. And these groups are, again, people with kids in their house, people who identify as Black or African American, and then people with a graduate degree, younger people, and people who earned less, lower income, less than $50,000 per year. Sorry, people who earn more than $50,000 per year. I said that wrong. Okay, and finally, looking at delayed care because they weren't able to get an appointment when they needed it. The average was 42%, and the groups that delayed more for this reason are, again, people with kids in their household, younger adults age 18 to 24, people with more education, and people earning more income. Okay, so I'm now looking at preventive screenings and immunizations. So we found that 60% were up to date on preventive screenings, 68% were up to date on immunizations, and of those who had children, which is about half the sample, 92% reported that their children were up to date. So we asked everyone who said that they were not up to date, we asked them to tell us why in sort of a fill-in response blank, and these were the top reasons. And we also asked why for those who weren't up to date on immunizations, either adult or children, and these were the top reasons. Okay, so now drilling down into some demographic differences for preventive care. So while 60% were up to date on preventive screenings, some groups were more likely to be up to date. So people with a household income of $50,000 or more a year, people with kids, people with more education, particularly a graduate degree. And again, 68% were up to date on their own immunizations, and groups more likely to be higher than average include those with more education, those who identified as either Asian or Hispanic, and those who identified as LGBTQ+. And for kids, the rate was uniformly high, and there were very little differences between groups.
Candace?
Mm-hmm.
We have two questions. The first one is, what did you include in preventive screenings? And I believe the answer is we use the task force definition of preventive screenings.
And we give them a link to the task.
And then the second question is, did you cross-reference individuals who were fully vaccinated against those who were fearful of getting COVID?
We didn't ask whether they were fully vaccinated for COVID. We asked if they were up to date on their immunizations. And so that included things like, I think we included just like in a paragraph, like in a parentheses, either COVID or flu, and then gave people a link to the task force recommendations. But we did not ask if they were vaccinated specifically against COVID. Good questions, though. Thank you. Let's see if I can move this forward. Okay. So on to geographic location. So we collected information on zip code of residence from our respondents and coded whether they're rural or urban according to this schema. And I just want to show you this so you can get an idea of what we mean by rural, which is everything in green, both the green, dark and light. Okay, so everything that I've shown you up until now has just been the relationship between two variables. And here I have the results of models that I built that control for all relevant demographics listed at the bottom of the slide. And this helps us to start to move away from simple correlations and closer on the spectrum to determining causes. So I've also included location, rural versus urban, and information on self-rated health. Respondents were asked to rate their own health as excellent, very good, good, fair, poor. So on the left, you can see that even after adjusting for demographics, the number of chronic conditions or need, if you remember from the model earlier, was a statistically significant predictor of delaying care for any reason, cost, COVID, or lack of appointment availability. And with each additional illness, the likelihood of delaying care increased. So location, urban versus rural, was not significant, nor was self-rated health. So this indicates that after adjusting for demographics, the people who need medical care the most are most likely to delay or avoid medical care. And now, because the data was all collected at one time point, we can't tell which came first, the illness or not getting care. So these individuals may be neglecting their care because they're so ill and have so many healthcare obligations. I don't know if any of you have ever had chronic conditions or cared for someone who does, but there can be a lot of medical appointments, taking a lot of time and money to make sure they happen. Or because they may be so ill that they neglected to get their care in the first place. So on the right, you can see that people with the most need are more likely to be up to date, or more chronic conditions, more likely to be up to date on preventive screenings and adult immunizations after adjusting for demographics. So while these same people are not up to date on their other medical care and treatment, they are keeping up with preventive care. As far as mental health, so now here, based on some initial findings and conversations with a committee member, I separated people who have comorbid anxiety and depression from the rest of the chronic conditions. As you may know, many times mental illness can impact an individual's ability to take care of their physical health. So while I didn't find a difference with delayed medical care, I did find that people with comorbid anxiety and depression had lower rates of preventive screenings and adult immunizations than I would otherwise expect them to have. As far as self-rated health, so remember, people were asked to rate their own health. And in addition, so those who rate their health poorly, fair or poor self-rated health, were least likely to be up to date on preventive screening. So they're down there at 47%. So I think this says that people who don't feel great don't stay up to date on their preventive screenings. And then finally, preventive screenings and adult immunizations are impacted by a potential lack of access. Respondents who live in urban areas are more likely to be up to date on their preventive screenings and adult immunizations, whereas those who live in rural, compared to those who live in rural areas. Okay, so just to summarize, so people with the greatest healthcare needs are delaying or completely avoiding the most for any reason. However, the same people are also the best at keeping up with their own preventive care. People who rate their health, people who rate their health poorly are not very good at keeping up with preventive screenings. And while COVID is still a concern, cost is clearly an important driver of whether or not people get medical care. And then finally, lost my slide. Finally, while decisions about medical care don't seem to be determined by geography, lack of access negatively impacts preventive care rates for people in rural areas. So that wraps it up, and I thank you for your attention.
Yeah, Candace, we have some questions.
Okay.
Specifically about cost, I think employers are most interested in what those cost barriers are. Is it because of their plan design, their insurance coverage, where there might be in a high deductible health plan, and so they can't afford to, sometimes have to make a choice between paying their electric bill or buying groceries or going to the doctor. So could you talk a little bit more about the cost drivers?
Yeah, so I think those are really good questions. And I think there's always the end of a research project. You can always say those are good questions for the next research project, certainly, because we didn't ask about, what their copays were, what they were, their deductible was. I did find that people who had a lower household income was related to the delaying because of cost. Whereas the other two reasons to delay, fears of COVID or lack of appointment availability, it was actually the other direction. So that indicates there's something about, just how much resources they have in their household. I think that, and this may be more of a discussion, because we didn't collect any information on deductibles and copays, but certainly preventive care tends to have less of a copay than other treatment related care.
Right.
So that is, although I don't have evidence for it, reading between the lines, that makes me think of it.
Yeah. So those are some of the things we're going to talk with Matt about now, because, we can make assumptions. I think that we would all agree that those who are lower income and are then also in a high deductible health plan, preventive care aside, which is, no cost, we have barriers to people understanding what their benefits are and that is available to them. We have people who, like I said, have to make a choice between buying groceries or going to the doctor and potentially having to pay the full cost because it's a choice that they can't afford, and it's out of their scope of what they can afford. And then we have kind of the added complication of access, whether it's access because of where you live, or you live in a care desert, or you don't have transportation, you don't own a car, so you can't get to the doctor, or as someone else asked in the Q&A, you aren't given time to go see a doctor. So we have a lot of employers who are looking at things like giving people time off to see a doctor, whether that's through telehealth or in-person visits. In a manufacturing or fully in-person work environment, scheduling may not allow for that. And so we have to come up with creative ideas how to tackle those particular things. So I'm just going to look through the Q&A really quickly here and make sure that there's not any other questions here for Candace in particular. Did that. So one question was, what affected the backlog in elective surgical procedures during and immediately following the pandemic? How on delayed care? That's part of the system issues that Candace presented. And again, a bucket that we didn't think was going to be as big as it was. And it doesn't speak only to elective surgical procedures, where it's very nuanced. In some communities, there may be a shortage of anesthesiologists and you can't get a surgical procedure done. In others, there's a huge backlog still from the pandemic itself in elective procedures. And so that catch up is still happening. I would say the question was, has the backlog been cleared? The answer is no, because people in this survey said they still aren't able to get appointments for those types of things. So I think we're still dealing with it. I think it's less than it was, but it's still out there. And the next question is for Matt. So we're going to transition into the discussion with Matt. And really, what's important to us and to our members at IBI is that we speak with employers and in the employer's voice and point of view so that other employers can try and tackle these issues. I think probably the biggest issue, and Matt, thank you for joining me, in looking at delayed care, it is very unlike other things that we look at. When we want to see how diabetes or MSK is driving incidents or duration or leaves claims or emergency room visits, we can look at a claim. There is no claim for delayed care. That's the problem. And so this isn't quite as easy to tackle as some of our other issues. So I want to talk to you, Matt, about how once you realize that this could be a future problem for employers at Honeywell, how are you tracking and measuring delayed care? And are you?
Yeah, sure. And it's not easy to do, Kelly, right? I mean, so we all lived through 2020 and we all saw our utilization drop off, whether it was preventive care, elective procedures, and started to see that come back in 2021. And so we've established at Honeywell sort of a full-blown measurement strategy that focuses on our 4 pillars of benefits well-being, which is physical, mental, financial, and individual. Individual really represents benefits that meet the diverse needs of our workforce and their families. And so with that strategy, we've implemented a full-blown measurement strategy where we're tracking across a series of dashboards and strategic objectives. So we can talk about physical. So At a high level, what we have seen is a lot of things have started coming back. So our preventive care numbers have improved, obviously from 2020 to 2021, continue to do so through 2022. So annual physicals, screenings, we're above prior years anywhere from 8 to 16%. So a pretty nice uptick, and we're above benchmarks. But you know me, I always say, well, that's great, but benchmarks suck. So we need to do better. And then we looked at, okay, well, the prevailing thinking from my perspective was, well, what are the implications of that? And so cancer is the best example I can give you. So our expectation was that people that were avoiding those screenings, and look, I get it, right? People either couldn't or didn't want to go and get those screenings. I think the real important piece was once we sort of got past, and I hate saying get past the pandemic, right? COVID's still out there, but you know what I mean. Really sort of pushing the messaging on how important it is to make sure you're getting those screenings. And the expectation became, from our perspective, is that we were going to see an increase, not necessarily in the incidence of cancer, but the morbidity or severity of cancer. And that has fully panned out. So historically, and those that know Honeywell tend to think of us as more of a kind of traditional manufacturing firm. It's not really what we are in the US anymore. We still do a lot of manufacturing in our aerospace division. A lot of the traditional manufacturing has sort of either gone away. So we really are what we call kind of an industrial software company. But we still make things. So we still do manufacturing. MSK was always number one. It was number one for a lot of employers over the years. Well, that's flipped. MSK is actually, we had a big uptick in 2021, right? And that either was because of deferred care, because there were no services available, and driven by the hospitals and ambulatory facilities saying, hey, this is a revenue play for us. We need to start getting these people back in and getting these services done, which isn't necessarily a bad thing if they're truly necessary. Where now cancer is our number one spend. And what we saw from 2021 to 2022 is our incidence rates decreased by 4%, our cost increased by 12%. So it's very difficult to sort of go back and look at 2020 and say, let's look at it again and try to project. I mean, we're past that. 2020 is done, and I think a lot of us are pretty happy that it's done. So it's really sort of looking at things like that and then continuing to track how we're doing, and then make sure that we as a benefits function are getting the word out to our employees on the importance of these things, and how much better the outcomes can be when cancers, for example, are identified earlier rather than later. My other concern is that there are people who maybe had gotten their mammogram on an annual basis in the past, and then 2020 came and 2021, and they just stopped, and maybe they're sort of this inertia is taking place. So we need to continue to make sure that those numbers are ticking up and we continue to exceed benchmarks, but not necessarily just benchmarks, exceed our own metrics, because we know we still have work to do in that space.
Yeah, no, and I agree with you. I think that this is a great reflection point in sort of our time of what is well-being and what does wellness mean, and preventive care. The industry standards that we shot for pre-pandemic were pretty crappy. So, saying that you had a 57% mammogram rate for those who, had a recommendation of getting a mammogram is not really a great goal to come back to. But I want to talk a minute about how you get people back to care, right? So preventive care we see coming back pretty well, again, not to where we want it, but at least to where it was. I think that a lot of employers that I'm talking to, certainly those large employers like yourself that are on our board, are really considering education more now than they ever have before. It used to be that, onboarding was a big thing and then it started just went away. But how much of this is a barrier in understanding? And what do you do about that? So again, preventive care is great. Do people know that, yes, you have a high deductible health plan, but you can still go get your mammogram or your colonoscopy?
And the answer is yes and no. And so we are a full replacement high deductible health plan. So we don't offer a traditional PPO. So I guarantee you there's people that don't realize preventive care is covered at 100%. And we have higher than average percentage of our enrolled population that doesn't utilize the healthcare system at all. And so we've done a number of things. One is we created a new microsite that is accessible by the public, because we also know that it's not necessarily our employees that are making benefits decisions. And we did a physical mailer to the home. I know it's old school, but we want to make sure if that spouse partner is the one making those decisions, they know they can actually take out their smartphone and actually go to the site and see the variety of different benefits that we offer and push messages through that site to try to reiterate the importance of preventive care. But now you've got to assume people are actually going out and reading the stuff.
That's
And
right.
so the other thing that we started doing is trying to get in front of employees more. So, whether we reinstituted benefit fairs, and for the first time ever at Honeywell, either myself or my team attended every single benefit fair that we did right at annual enrollment last year. So they had an opportunity to talk to us, and we could almost force the message onto them. And then we also started doing a lot more benefit presentations. It's tedious, connecting with a lot of our employee resource groups, whether it's our women's group, whether it's our LBGT plus group, whether it's our Black employee group, and just sort of tailoring messages that are specific to them, because we also know there's ethnic and gender disparities in healthcare. So making sure that we're connecting with the opportunities that exist, and in the process now of figuring out how do we equip managers with the information that they need to push to their employees in a way that's not sort of invasive. But we also know that when people have issues, they're not necessarily going to their local HR person. They're probably talking to their manager. So we're not asking our managers to be benefits experts, but at the very least, point you in a direction where those messages is.
And I'm hearing that from a lot of employers I think the conversation started with mental health and reducing stigma and recognizing mental health needs, that employers went out and trained their frontline supervisors and managers to just be more aware. But in that conversation, they also trained them on what benefits are available to people, which was an overall halo effect, good thing, right? So now, if I'm having a conversation, this question came up in the Q&A, preventive care is covered at 100%. There are no barriers. The barriers have been removed, at least for now, and we hope Texas doesn't change all of this. But let's say
we're self-funded. They can't force us to do anything.
I know. But for those who aren't, I don't want this to change in the future. But for now, those services are covered at 100%. So there is no barrier in place. The barrier is in the understanding, and that people understand that they have that access. And so having those conversations, making them part of onboarding every time. I have another employer, Matt, to your point of communications. Old school works for some populations, and you should stick with it if you know it does. I have one employer who actually did this. They send everything through email. They don't send paper anymore, but they knew that sending it to their manufacturing male population was not going to get the word out. And so every email just has a little red button on it that says send to home. And the employee just has to click the red button, and it gets sent to their wife or their significant other or their husband or whomever. And that had a huge increase in awareness of whatever it was that they were communicating. So these are the types of information that we need to continue to kind of drive home. And some of them are old school, but if they work for your population, your culture, use them.
Well, and for a portion of our population, we have to be, because we have what I have called the unplugged population. They don't have access to a Honeywell device.
Yes.
So the best we have when they're on site in between shifts is they're going to get lunch, and they happen to walk by a screen by the break room, and fingers crossed something about benefits flashes across the screen and not about something else. So they're very difficult to connect with, but obviously an integral part of the work that we do at Honeywell. So a lot of those folks, you've got to get it to the home, even if the employee is interested. But I guarantee you there's a portion of our population that doesn't recognize preventive care is covered at 100%.
Yeah. Great question from the audience. Craig asked, are there strategies to support preventive care and helping men access care? And certainly in a highly manufacturing environment, you're probably dealing with a higher male population. Delayed and normal challenges of leaving work seem to apply relating to access and confidentiality and cost. How do you address giving people time and
Yeah.
still meeting business needs. That's a tough one.
So it is tough. Now, our manufacturing population's not as big as I think a lot of people would think it is. But we are in the US 75% male. So very heavy male population. Now, we tend to be a little bit older, but not old enough that these people haven't gotten past their invulnerability syndrome, where I don't feel bad, so I don't need to go get these services done. So, we try to bring very basic care to them. So we reinstituted our biometric screenings last year. There is a penalty associated with it. And it's the typical stuff, right? It's BMI, it's blood pressure, it's HDL, LDL, and then we actually do a tobacco screen too. But we have about 75 sites across the US that have 100 employees or more. And we did at least one day at every single site in the United States last year.
Wow.
So it's 375 different days of events, because we wanted to make sure. And look, it's the basics, but it's the person that is just not interested in utilizing healthcare, doesn't really care about I'm never going to get to them. But if I get to that person who, was again in the office, building engines, as an example, during the course of the pandemic, the stress of life of living through a pandemic could affect the blood pressure. So maybe they don't realize they're hypertensive, because when you're hypertensive, you generally don't feel bad.
Right.
So hopefully going through that process gives them a view into potential health risks. And that's sort of the impetus for that portion of the population to get them to go out and take advantage of some of the basics and some of the other programs that we offer.
Yeah, I'm talking a lot to employers about getting back to basics. It seems like with this sort of reset that we're in the middle of here and the opportunity to reset, employers are talking more and more about the things that really impact the bottom line. And when we look back at the last 36 months and all the sort of products and solutions that we might have slammed in without a whole lot of RFP and ROI and BOI to proof points to put in place, because we had to, not because it was a choice. Now that we have a chance to reset, I think we're looking back at the things we always knew worked and affect trend and health outcomes, and now add into that employee satisfaction for attraction and retention, because that's one of the most important things at the top of the list now instead of cost. So how will employers look forward at solutions, knowing all we know now, that'll support people getting back to care? And specifically, one of the Q&A questions was around telehealth. So as you know, we did a research project last year on telehealth. And I think that a lot of employers, many large employers, I'll say national account size and larger, put telehealth in 15 years ago because it was the gold standard and everybody did it and it was the shiny new thing. And so we all put it in and we left it. Obviously, it became extremely important to have a virtual solution during the pandemic, especially for mental health conditions. But when we looked back at the data, what we found was over 80% of the people who used virtual care during the pandemic did not use that large national provider that their employer offered them for telehealth. They used their own doctor, which we're not complaining about. That's actually a good thing. We'd like you to see, if you're going to use telehealth, we'd love for you to see a doctor who has your chart in front of them and knows what medications you're taking, et cetera. And so I don't think that's a bad thing, but that's a good example of solutions, old solutions that have been in place a long time that employers are paying a lot of money for, that might not meet the needs of why they were implemented many years ago. We put them in for access, and we found that people in rural areas aren't using it because maybe they don't have phones or they don't have internet. And so are we solving the problems of today with the products and programs of yesterday? How are you approaching that for moving forward?
Well, a couple of comments. So one, I agree with you, right? Obviously, most medical care that can be delivered virtually through your traditional brick and mortar locations was done virtually. And obviously not everything can be. And a lot of those providers have continued on because the business model makes sense. There's always been a concern that, okay, historically, folks going through medical school don't take a class on how to deliver virtual care. So is the quality where it needs to be? And so I think that's evolving. I think virtual care is a large opportunity, has a large opportunity to expand, because people, just like everything, people got used to doing things differently, whether it was working from home. So we've maintained a hybrid working model. Caregiving. I know we're talking about healthcare, but this touches, if you think about sort of the spectrum of well-being I talked about earlier, this sort of hits across everything. So I continue to see virtual care expand. I think, the capabilities and the ability to assess the quality of the services, and not necessarily the quality of the doctors, because that's difficult, right? I can't go out and start saying I'm in Charlotte that I'm going to start knocking on doctors' offices and, asking the doctors how well they're doing. But the vendors that facilitate that, are they triaging care appropriately? Are they maintaining integration with the traditional health plans? Because we still have the traditional clinical programs offered through our carriers.
Right.
And when they're accessed, they can work. So we've effectively, again, back to basics, right? A lot of companies want point solutions. We didn't go crazy with point solutions. So we still have our carrier-based programs. And so we've gone in and we've audited them. Because if they're not working, these are people that are truly ready to engage and help to get their care managed. The one thing we introduced in October of 2021 was mental health support through one of the few point solutions that we do offer. And it's really about navigation. It's about understanding. And, I make the argument that not one person in this country or around the world didn't deal with additional stress or anxiety, because unless you're 110 years old, you've never dealt with a pandemic of this magnitude. Right. So, and people are more and more willing to engage in mental health, but then we can get into the whole access issue that exists. So I think from a mental health perspective, virtual care really can be a difference maker. I hear you on some of the rural issues, but from a time perspective. So think about my line worker who's working, an 8 to 10 hour shift. And that's, from call it 8 to 6, doctor's offices aren't open. Right. So, maybe if they need care, whether it's general medicine care, behavioral health care, virtual primary care, they can access that outside of normal business hours and not have to worry about taking time off of work, because we run a very lean organization and people want to be there. They want to make sure they're getting the work done. So I do think that will continue to evolve, but it really needs to be integrated in some of the newer models, whether they be ACO solutions, PCP first, virtual PCP first models, whatever, narrow networks, integrated through so everything can be fully integrated so people's overall health can be managed. The one thing that concerns me when I look at our data is when we look at people that have had 2 or more primary care visits in the course of a year, which isn't a lot, that's actually declined from 2021 to 2022. And I think that's less about people wanting to work with a primary care physician and more about the primary care shortage that we have been experiencing in America for years now, that is only getting worse, quite frankly.
Mm-hmm. Yeah. All good points. Quite a few people are asking about sort of the tail end long-term effects of delayed care. And obviously going into this, that's why we did the research, because our members, IBI members, were concerned about what's going to happen 2 years, 3 years from now. And Matt alluded to the effects on cancer and that was our fear. If someone is not being screened early, if someone maybe who is detected in early 2020 pre-pandemic and didn't receive treatment now comes into the medical system as a high cost claimant on disability. And so, that lack of claims for that point of time where we didn't know what we didn't know, we didn't have a claim to look at and to track and to enroll somebody into a cancer program. Did that then turn into an STD claim, or depending on the diagnosis, multiple FMLA leaves? One question was, have you seen an increase in your population in conditions such as cancer or MSK, or even the answer I already know for mental health is yes, due to delayed care? Are you seeing disability claims for those diagnoses?
We are. We're seeing an increase across the board for those diagnoses. Mental health utilization has increased, which isn't necessarily a bad thing. But it continues to tick up from a short-term disability perspective. Yeah. Same thing with cancer, as I mentioned earlier. We're seeing a reduction in incidence and increase in cost. So those short-term disabilities, and then tag on to that. Now all of a sudden, if I think current state, now we're looking at medication shortages, cancer medication shortages.
Right.
So you'd almost equate it to the national health system in the United Kingdom, where someone who needs a knee replacement can't get in to see a doc in 2 months, can't get the surgery until 2 years.
Right.
It's not that
Yeah.
bad, but it's, we're dealing with a lot of those same things. And it all sort of has to do with the economic environment we've been dealing with. I think, Candace talked earlier about the cost of care. And as I said, our population is in a full high deductible health plan. And so I don't think anyone really predicted the inflationary environment that we would be living in.
No.
And while it's come down slightly, I think about my manufacturing employees, maybe earning less than $50,000 a year,
Yeah.
Even if they know preventive care is free, what if there's a diagnosis? Maybe they're avoiding that care because they have to pay the bills.
Right.
They put food on the table, or they can't afford their medications.
Yeah, for sure. And we're definitely seeing that. We're hearing that. It's just a matter of how do we combat it and put solutions in that bridge that gap. I know some employers are looking at, financial well-being programs to help people understand, or even have to maybe borrow money against their pay in order to have some of these procedures done. I had an interesting question from the audience about not disability, but did you see a direct effect or correlation to an increase in workers' comp claims during or post-pandemic because people maybe weren't getting care? Were they then blaming it on workers' comp injuries or illnesses?
A great question. Unfortunately, I don't have a view into our workers' comp data. My guess would be yes.
Yeah.
Given all the things we've been talking about. Okay, so I'm on the line, and again, I'm going to use engines because I think most people know that one of the things that we build are engines for airplanes. If you're on the line and you're physically ill, but you don't feel like you can stay home from work because you need your pay, and maybe you've got some mental issues or financial issues, are you really able to be as effective as you need to be in putting together, engines that are ultimately going to be carrying people around the globe on commercial aircraft? And so, yeah, my guess would be if I were to reach out to our risk folks, they would tell us that we have seen it. I just don't have the data to be able to speak to it.
Understood. Very interesting question regarding virtual care, because this is certainly one of the new vendors, type of vendors that have come into the market since the pandemic are like asynchronous care visits. So when we speak of virtual care, what are your thoughts about asynchronous care visits, either to supplement with live video or to access for episodic or urgent reasons, like that you're actually interacting with a provider?
Give me an example. Give me an example of what you mean.
Now some of the virtual care can have devices that you can use on video where you can, show the doctor your throat or your ear, or perhaps if you're having physical therapy, you could be using the video version of that to complete your physical therapy.
I think they actually can be impactful, and physical therapy is the easy one, right? There's the handful of companies. I've actually tried a few of them. Some are decent, some are very difficult to actually use, where I needed someone to actually hold the iPad so I could get in the best position to do my little exercises. But I think so. Take physical therapy, for example. I think it's very important because a lot of people don't follow up with physical therapy in an office setting or a hospital setting, because now you've got to get in the car, you've got to drive there, you've got to, go into the facility, versus doing it virtually can help with compliance. The other thing I think about is cardiac rehab. So we know in the United States, the average adherence to cardiac rehab is, call it 18 to 20%. I'm probably being generous because again, so I have a cardiac event, I have whatever, my stent put in, and I've got to go through cardiac rehab, but feeling better, want to be at work. And so I just say, you know what, I'm not going to drive 20 miles. So we've seen a couple of startups that are entering that space. So I think that will continue to evolve because it removes the time barrier. It can, in certain instances, remove some of the cost barrier if delivered in a more cost-efficient manner, and allows, the benefit programs we offer support the business. Because when my employees are able to be at work and productive, supporting the needs of our customers and our clients, well, then the business becomes successful. So absolutely, I see that it's going to continue to evolve, right? We have 75 million healthcare tech startups coming into the industry on a regular basis. And so that will evolve just like traditional telehealth, which was only general medicine. And then you started to see, oh, well, dermatology. Oh, okay. And now behavioral health, now virtual PCP, now chronic condition management, now physical therapy. And it will continue to evolve, especially as these organizations. But I would warn, you can't just put this in and believe it's going to be perfect every time. I mean, you audit your medical plan that they're paying claims effectively. You audit your clinical programs to make sure they're delivering clinical care effectively. You've got to audit these things and make the care being delivered is effective.
Yeah, I couldn't agree more. And this is striking a lot of Q&A with our audience. So two of the other big questions that have been asked, and that obviously we've had multiple conversations about, and many employers are, when is it financially worthwhile? And obviously Matt's been with a lot of, Fortune 100 companies, and as a consultant has been dealing with this his whole career. When do you start looking at plan design, and not to mention the downward cost shift from the economy and the recession and it's inflation, et cetera, of knowing that you probably are having your CFO ask you to save money, not spend more money in the health plan? When is it time to start really looking at the plan design itself and potentially cost shifting or bringing a copay plan back, or, changing your high deductible health plan? And that's question one. And then 1A is, do you then also look at your incentive plan if you have one, and think about if it was carrot for many years and you're paying out a lot of incentive dollars to get people to go to preventive care. And we all know that doesn't work, that we get highly engaged, well people who make money in those scenarios, and we're not really getting the people we want to target. Or do you shift that thinking to more of a stick approach or a stick-ish approach, where you're, sort of earning either credits or being penalized with premium when you don't do the things that you need to do in that aspect? So I'd love your thoughts on those two things.
Yeah, so I think most employers are getting cost pressure from the CFO, right? Potential recession, can argue whether or not, hey, we're probably past that, or it's not going to happen. But, many employers in a lot of different industries have been making job cuts. They're looking for cost savings opportunities. They take one look at the benefits program and say, we're spending, $500 million on healthcare and other smaller programs. I want X millions of dollars out of that program. Well, you have to be able, that's why our measurement strategy was built. So we have an executive dashboard that can go to leadership and say, okay, yeah, we're spending $1 million on this program. Here's the impact that it's having. So for example, we avoided X number of low back surgeries, and that would have cost us Y, which actually pays for the program in and of itself. And then on the flip side of that, I think you need to think about kind of pulling the Band-Aid off a little bit on. So you mentioned, I know a lot of employers, especially during the pandemic, said, we have to throw solutions, right? Let's throw as many things at them as we can. Well, now we need to figure out what's not working, right? You can't just sit on these things and cross your fingers and say, gosh, I really hope this is having an impact. Because if it's not, well, maybe you pull that program out, you pull those dollars, maybe you don't give it back to the business, maybe you reinvest it in something that is working and expand that program. But yeah, I think we're going to continue to see cost pressure. And I think, the way we think about it is we continuously evaluate our programs. If we can identify efficiencies, we will take those efficiencies and we'll reinvest them either in expanding current benefits. So virtual care, we're looking at creating either a cost-free or minimal cost model for virtual care. Because again, it's one of the things based on the CARES Act and the extension of that we can do, because we are limited to what we can do in a high deductible health.
Right.
So we are limited in that fashion, and we're looking at things like preventive medications. We offer a series of preventive medications for conditions like hypertension, diabetes, cholesterol at no cost. And it's not all encompassing, but it's a start. And to remove some of those cost barriers where we know if our population maintains medication adherence, it's going to avoid those large cost impacts in the future. Now, that sometimes becomes difficult to try to explain to a CFO, because you start to get into the conversation of cost avoidance versus cost.
That's right. That's right. They
But-
hate those cost avoidance models.
I know, but at the base level, what I think is you continually have to manage costs, but you need to understand that you are impacting your ability to attract and retain talent through your benefit program.
Absolutely true.
I
And
think
more,
most-
even more so with certain generations. So you have to know your population, know your culture,
And,
right?
and I think, you need to partner with other groups within HR to say, okay, what is the true dollar cost? If someone at this level leaves the organization to, okay, backfill, then recruit, then hire, then train, versus retaining that person who's doing an effective job in whatever role that they're in, because you've got these programs in place, or that person who, maybe didn't get their mammogram and ultimately got diagnosed with stage 3 breast cancer versus stage 1. How long is that stage 1 person going to be out of the office versus that stage 3? Or
Yeah,
that much on the surgery piece. And
Yeah.
so it's difficult. I'm not saying it's easy when you think about measuring productivity, measuring, presenteeism. But there are ways to get to it. You just need to make sure you have to think outside the benefit spectrum into other groups within the HR function and the finance function to pull that data in to make that case.
Yeah. Thank you. Thank you, Matt. I know we're over time, so thank you for those who hung with us. We will answer the questions in the Q&A after the presentation if you submitted them with your name and email. And I want to thank Matt for joining us today and Dr. Candace Nelson for doing the research and presenting for IBI. And thank you all for taking the time to join us.
Thanks, guys.
Take care.
Bye.